Greetings, I'm Yvonne, Staff for Science for the Public, and I welcome you to our Contemporary Science Issues and Innovations program, today broadcasting from Belmont Media Center, Community TV. You are aware, no doubt, that the U.S. is the world's leader in science research and certainly medical research. You are also likely aware of the huge funding shutdowns affecting major research agencies such as the NIH. Today, we learn from a prominent cancer researcher how cancer research is done first, and then how these complex studies rely mainly on federal funding, like the NIH. Gerald Denis is, among his numerous titles, the Shipley Prostate Cancer Research Professor at Boston University's School of Medicine, and he is also co-director of the Boston University Cancer Center. Dr. Denis has made many contributions to cancer science, which he'll describe. He'll also explain the importance for graduate students, lab experience, and postdocs included there too. And all of that underscores the necessity of government support and stable funding. Dr. Denis, we are honored to welcome you today.
Oh, well, likewise.
Thank you for
Yvonne.
joining
Yeah,
us.
no, my pleasure. Thank you.
Okay, all right. Let me ask you then to start with just a little background here on the cancer research in general. And in terms of medical research, since the United States is such an important one in that respect, why, and I'm afraid of asking this even, why is this research so important today for health?
Well, I think we've been understanding cancer as a problem for hundreds of years, but there's always more things to learn, and sort of the molecular mechanisms of things like breast cancer, for example, are still only partly understood, and so research has not been completed. So I'm sometimes asked, when will they find a cure? And I have to say, the mortality from breast cancer used to be 100%.
Yeah.
And it has fallen dramatically to now something like more like 20%, so this is great news.
Yeah.
And some cancers have made very little progress at all, like lung cancer, whereas others like, testicular cancer in younger men, 100% cures. So it's not a simple question with a simple answer like that, but it's really 100 different diseases, each of which have their own kind of outcomes. So we don't understand some of them as well as we do others.
Right.
That's partly why it's so complicated.
Right, but so it's really critical that we provide this research in order to get to understanding the disease.
There's a lot of unanswered questions.
Yes,
Despite the progress, many questions remain.
Okay, and can you give us a description of cancer research? How do you do it? Do you just look in a test tube all day? Or
Right. Well, so many experiments are done just with cells or cell cultures or with animal models, but also those experiments talk to what we see in the clinic. So often the clinic experiments say, oh, well, wait a minute, why is this patient having metastasis? We don't understand that. Can we model that somehow in a well-controlled environment? And then often the insights come, oh, maybe we should consider this patient this way, or here's a biomarker to say, this patient's at risk for a brain metastasis. We should monitor them more closely. So that's a great example of how the bench and the bedside are kind of in a conversation.
Okay, and when you get subjects to participate in in research in general, I'd like to ask you, since diversity is almost a bad word right now, why is diversity important in doing these kinds of studies?
Right, that's a great question. So for example, African American women are more likely to develop obesity and diabetes than age-matched white women, and then the complications with that. And also Black women are more likely to develop triple-negative breast cancer. And so a study that includes only white women in it will not help us understand why Black women are getting more breast cancer. So it's important to have a diverse range of subjects, different ages, different races, different backgrounds, in order to fully capture what's the picture of breast cancer, let's say, in a large population. You can't study a narrow slice and expect to have recommendations that affect everybody. That's the reason.
Right, that's a really good information. And then one more thing along the line, just general cancer research. You train a lot of graduate students and postdocs and so on. Could you explain why this, I guess, the lab experience is so important for them, if it is?
Yeah, it's almost like parenting, I would think. It's a daily interaction helping students understand their experiments, and especially when things don't work. So it's developing resilience, it's developing an understanding of why did this experiment not work, and sometimes the experiments that don't work are actually where the insights are. We go, oh, really? Oh, that's really weird. What do you think? And then we discuss as a group. And sometimes it's in the discussion that we have tremendous insight, like, oh, let's try that next week. And then, so that's how we make progress. That's how things move forward.
You wouldn't get this just out of textbooks by any means.
No.
But you bring up something that's really important there, that scientists often say, hey, look, I make mistakes every day. I fail all the time. It's part of it. You use that to evaluate and start over and go forward. You don't start with belief.
Right. So there are mistakes an expected result is one thing. An unexpected result is very interesting because that's the route to an insight.
Yeah. Can you give an example of that?
Yeah. So sometimes you expect, let's say, cells to move in a certain direction, and in fact they went the other way, and they're moving, but just not the way we thought. And we think, why is that happening? We discuss. I wonder if, and then there's an insight. Let's try that. And then it works. So that's very exciting.
Yes. Well, I can see that for people just getting into a field, going from textbook and then into the lab and really learning.
Useless.
Well, I didn't want to say it.
No, everything in the textbook's wrong because it's not up to speed.
Right. Yes. Yeah. But the real on-the-spot learning is extremely important.
Well, Yvonne, I'll tell you, it's like an addiction. It's so exciting when things go well or unexpectedly well. There's nothing like it.
Yeah, I'm sure.
That's why I love it.
Yes, yeah. I'm sure.
It's a privilege to work like that.
Right,
yeah.
Which takes me to your lab,
yeah.
and then to get an idea of what you do in your lab, and then the impact of the research funding. So first of all.
I work a lot in breast cancer and prostate cancer, especially in patients who also have obesity and diabetes, which are very common in safety net hospitals like Boston Medical Center, where patients don't have just one diagnosis, but often several. Obesity, diabetes, asthma, lots of complications. And so these diseases are talking to each other. And so that's why we're interested in them. And so this idea that you can simply study one type of cancer and expect to have an answer isn't adequate, at least for our population. So safety net hospitals are places where often people who are underinsured or have lots of complications go for their medical care. And they're often not as well educated, perhaps, or perhaps they're frightened of the medical system. And so we haven't earned their trust. And so they often present very late, so often with metastatic cases. And so this is very difficult. So trying to understand how these systems are talking to each other is really important.
Yes.
We think also that blood glucose and metabolism are very important for progression of some of these cancers, but that's primary care. So your oncologist doesn't ask you, how's your blood glucose? That's your primary care doctor. And yet we think for these patients, these systems are completely talking to each other. And that's ignored by most of medical oncology. So that's the innovation I think we're bringing.
Right. And you treat a whole slew of cancers, right? Your major one is the breast cancer?
It's breast cancer and prostate cancer.
And prostate cancer. And can you give us an idea of what your day is like in that lab? It must be great fun.
Well, my day begins when the hot shower hits my back in the morning. Often I'll have an idea that I've been dreaming about. It's suddenly becomes clear before the coffee.
Right, even before the coffee.
That's when my day begins.
Right.
Yeah.
It's interesting how many people say great ideas come to them in the shower.
Yeah, for me, that's true for me. Yeah. And frankly, I never stop working. I dream about it.
Yeah.
And it's kind of 7 days a week, but it's not taxing. I love it. I mean, it's an identity. It's not a job.
Right.
And a lot of people in my field feel the same. It's we would never do anything else.
Right. That's very common with research generally, that it's an addiction.
It's an identity. Yeah. It is who we are.
Yes, exactly. And then in your lab, you work with a lot of graduate students and so on. And before we get to the funding issue, you in an article, it's on our event page and our website, that in the conversation about the silo issue. Would you tell us about it? Because this we do not hear about at all, and that is a real necessity, what you had pointed out there.
Yeah, one of the problems is that if you want to think about breast cancer, the people who study breast cancer go to breast cancer meetings. But this whole question of obesity and diabetes is a separate branch of NIH. These are separate journals, they're separate academic meetings and separate conferences, they're separate memberships to separate societies. These people tend not to talk to each other. Cardiologists don't go to cancer meetings, and yet somehow I think they should, at least for our patients. So that's part of the problem. It's like these diseases are talking to each other.
In that article, if I recall, you gave a wonderful example of the fat cell talking to the cancer cell, like they were good buddies. Could you just go into that a little bit?
So if you think about the breast, so 99% of the cells in the breast are fat cells, and the tumor cell is just a tiny portion of them. And so these tumor cells, as they're growing and dividing, are surrounded by a vast number of fat cells. And in a person who's ordinarily metabolically healthy and lean, that's fine. We think about the tumor. But in a person who has obesity and diabetes, all those fat cells are abnormal. And they're talking to each other in a very conspiratorial and dangerous way. And the more dangerously abnormal those fat cells are, the much more aggressive the tumor. And so we don't understand why that is. That's a lot of molecular crosstalk that's not considered in the standard of care in medical oncology. So that's the opportunity, I think. And what is this crosstalk? What are the molecules? What's the conversation? It's a dangerous conspiratorial conversation happening in that environment.
Yeah.
And so it's really about the microenvironment of that tumor. Lots of different cells are talking to each other, and we want to understand that conversation. We want to eavesdrop on that conversation and stop it.
Right. I have the sense, because you mentioned before, people are so specialized, that's the silo effect, that people are so specialized, they don't talk to each other, they don't know these different fields of research. And it seems as though you need a different kind of training, do you think?
Yes, I think especially in hospitals where we see a lot of patients who have these complications, in elite academic medical centers, often patients are wealthy, healthy, and white, and that's the only thing wrong with them. They don't have these other complications, and so the crosstalk's not there. And so, but these are the centers that set the rules for everybody else, and they set the patterns and the clinical trials. So I think these safety net hospital questions, and it's not just Boston Medical Center, it's Cook County in Chicago, it's Grady Hospital in Atlanta, it's San Francisco General. So these are the hospitals where patients really do need to be considered in this much broader way. That's not part of the standard of care at the moment.
That is unfortunate. Can you tell me if overseas, in other countries where you have a different structure for health systems, for health care and so on, do they pay more attention to these kinds of things, or are they siloed also?
I wish I could say they do, but they don't either.
There we are.
Well, everyone follows the American pattern.
Yes, well,
and so that's the problem. And so, for example, in India, there's a huge prevalence of diabetes. It's the diabetes capital of the world. And breast cancer has doubled in India in the last 10 years. But the government's not prepared for the tsunami of cases that are going to come because of these metabolic complications among women in India. So it's the same thing. And we're talking there with a population of 1.2 billion.
Yeah, right.
The number of excess breast cancer cases to be expected in India is in the tens of thousands.
Yeah.
So the government's not ready. So.
Right. So it's sort of everywhere.
It's an international problem.
And that's the silo thing just all by itself.
Yeah.
That's very interesting. Are you doing anything to try to push people in another direction with this?
Yeah, well, I have a collaboration in India where I'm going to be going in the fall to actually discuss with my collaborator.
Make noise.
Yes. Yeah, this is the Indian Institute of Science in Bangalore. And so some investigators there are aware of it,
right?
But they're trying to raise the national level of the conversation. Yeah.
Right. But it needs to be universal, apparently, from what you're saying.
Well, and I think it also helps us understand breast cancer in the United States. I mean, the pathways are parallel.
Right.
What we learn in India will help us understand breast cancer here.
Right.
I mean, the countries don't exist in isolation. I mean, these things we all talk to each other, right?
Yeah. There's one more thing I can't resist. We have a famous institute here which stresses genetics. So if you have freckles, that's genetics. If you get a pimple on your nose, that's genetics. If you get breast cancer, that's genetics. It's that tendency. It's your fault, you see. But that is divorced from the issues you're talking about, the background issues there, the effect of obesity and so on. Do you
Yes.
see that? Do you think that we're guilty?
Yes. The more I study genetics, the more I feel that it's really the environment that's actually playing a greater role.
Yes,
Exposures, diet, exercise,
Yes.
even the neighborhood where you live.
Yes.
If there's a lot of pollution locally, that's much more important than your family history, I think. I mean, to be fair,
Right.
there are some, so like the BRCA gene, for example, is sometimes very, very important.
Sure.
But most of breast cancer is sporadic. 90% of breast cancer does not have a single genetic cause. It's likely to be related to exposures or smoking or other factors.
Right.
Over which some things are control, you can modify, others you can't.
Right.
And so neighborhood's one of them.
You had a slide, I think. Did you of showing where the
Yes,
cancer?
we could. So if there's a slide handy, we could pull it up about lung cancer rates across the country.
Yeah. Okay. Can you bring that up?
Right. So this is a slide showing lung cancer
Look at that.
mortality by county across the United States. And one thing you'll notice is that risks are not spread evenly. So the major problems are the Ohio Valley, Lower Mississippi Valley, Southern Eastern Seaboard, and a few counties in the West, and Aroostook County in Maine. So much higher rates of lung cancer death. Middlesex County in Massachusetts, as you notice, is very, very low. Well, not many people smoke in Middlesex County.
So that's interesting, but it's the smoking that's really the thing.
But this is also an indication that these are counties where we should be allocating resources for smoking prevention, for lung cancer screening, and so these are also political considerations. So those members of Congress need to understand that their constituents have higher risks of death from lung cancer, and what are they going to do about it?
Right. And then there are areas, I don't know if it's not necessarily lung cancer, but I thought it was like Cancer Alley in Louisiana and so on. So that's not necessarily smoking, but
other
the
exposures.
environment stuff.
Yeah, or air pollution and particles in the air.
Right.
Yeah, absolutely.
Right.
And groundwater.
Groundwater
Is heavily contaminated in the lower Mississippi Delta.
That's really important, and not only there, but heavily there, right?
And also heavy metals like arsenic and lead. For sure.
Right. Because when we see lung cancer, we automatically think smoking, but it's not.
Or asbestos or particles. Airborne particles.
Exactly. But from what you seem to be indicating, that there is like an economic aspect of this too, social economic aspect. So these are poor areas tend to get hit.
And so these are comorbidities of poverty as well.
Yes.
And also lack of political efficacy. So a lot of people feel powerless when they live in these areas. And there's high rates of drug addictions and fentanyl and everything else. So there's a lot of hopelessness in these communities.
Right.
And they're very beaten down.
Right.
And they're ignored.
And another thing there is that the diets tend to be poor, that they can't get fresh fruit and vegetables and things like that.
That is absolutely true. And that is associated with the obesity. And that is on actually the next slide, if we could have that.
Could we? Yes,
so
because obesity is huge.
So this is CDC data for obesity by county in the United States. And you'll notice it almost overlaps with the lung cancer mortality
data. Yeah, that's interesting.
And I'm not going to say specifically, but it overlaps with political patterns, I'm sure you can imagine. So these things relate to each other. I have a little list here on the left of the numbers of CDC programs that have been cut just as of this week.
Look at that.
Related to disease prevention and TB prevention and STDs, and all of these programs are on the chopping block. And we're going to lose this information, because monitoring for these kind of disease prevalences and incidents, this requires money and people to do. And so if they're all fired, how are we going to learn this?
Yes,
right?
Not only that, but if you drop that monitoring for 6 months, a year, you're in trouble, right?
Well, as I was saying, like if you see there's a hot spot of asthma in kids in a certain neighborhood in Dorchester, and now suddenly no one's tracking it, how would you know what to do? Governments require evidence to make decisions. And so if we say, look, there's 100 kids with asthma on the street, something's up here. We only know that because we captured that information. People did the analysis. The computer programs gave us the result. And then now we know we must take action. But without the data, we're flying blind.
Right. And data is a very big thing, and they...
It's also a political decision not to collect data. So Texas just stopped collecting maternal mortality data. And why do you think that might be?
Right. right.
In the same way that Florida stopped collecting COVID mortality. These are political decisions.
Yes, that's right. I can't resist asking you, so you don't have to answer, but we've seen this huge attack, not just on the funding, but on all of this stuff that you're not going to monitor these kinds of conditions. You'll throw it all out. Why? What would be a political excuse for that?
Well, if you don't know, then you don't have to take action.
You think it's just that? That's all.
I'm actually very cynical. I'm like,
right. Try not to be so cynical, but
well, I think
no,
if you
really,
don't know, then nobody can hold you to account.
Yes.
If there's no data,
yes,
nobody can point to it and say you're not doing anything about it.
Yeah. Maybe that's the thing. I don't know what it is. Do we see this elsewhere in the world?
Well, the American public has to demand that this data be collected so that we know.
Right.
Because it's about our health. Right.
Right, and we should need to be better informed as a public that data is collected and that it needs to be continuous.
Well, if somewhere on Tupelo Road the water is contaminated, I want to know.
Yeah, right.
Everybody wants to know. I mean, kids in the neighborhood, like, I'd want to know.
Right.
If nobody tells me and nobody knows, and my kids get sick, I feel angry and powerless, right?
Right.
So that's what government is for.
Right, and that is a problem that people don't know that the water is full of PFAS.
But that's
so
why you should test the
right.
water to find out.
Yes,
right?
well, we have the testing.
Yeah.
I'm not sure that it's publicized all that much, but the other part of it is that sometimes it's just sort of discarded, that at the federal level sometimes the information does not go through, so it's a problem.
Well, this is contentious too, because the rates that you want to say how much lead is okay.
Yeah, right.
You know, these are contentious and political points too. How much air pollution is okay?
Yeah.
How much ozone? How many contaminants are we allowed to have in our water?
Yeah.
You know, you can set the level.
Right.
Right.
And we've been going through this decade after decade. It has taken so long to get after some of these things.
These are political.
Yes.
These are political
That's
considerations.
what I mean, right. And we need to get kind of past that somehow.
Well, the
or
American
especially
people
for
needs to
tax-
decide. Like,
Yeah,
do
right.
we want to know or not?
Yeah,
Really?
yeah. But they need to be informed in order
Yes.
to be active on that. Okay. I'd like to go into the funding business. So the attacks seemed like especially directed at indirect costs and stuff. Would you please explain this funding thing and include the direct and indirect costs so that we, the public, know something about it?
So the indirect, it sounds like it's somehow not important.
Yeah,
but
right.
What it really means is it's the cost of keeping the lights on. And the secretarial support, janitorial support, the water, the power, everything. So it's not the actual cost of the experiments themselves, but everything that keeps the building running. And so, for example, Boston University has a rate of 65%. So for every $100 that comes in to support research, an extra 65 comes to keep the lights on. And so that's the indirect. And so there's a proposal to cut that rate to 15%. Who's going to make up the money? BU doesn't have that money. All the universities are scrambling and panicked because they can't run with like a sudden overnight change in their budgeting like that. And that's why it's an attack on universities, because it's going to paralyze and bankrupt universities and hospitals.
Right.
And that's deliberate.
Right. More on that, because I'm not sure that people know, these research universities, how much the country depends on the research universities.
Yes. So for every 100 drugs that received FDA approval, 99 came from NIH-funded research. So it is the essential pipeline to create new drugs and new cures and new imaging technologies and new devices. And furthermore, as investigators, we are all dependent on NIH funding. So I do not essentially have a salary from BU.
Right.
I must raise my salary through NIH grants.
Right.
My students don't have university support. My grant pays for their stipend. And so if the grants go away because NIH goes away, I go away, and all my students go away, and all my colleagues go away.
Right.
So we're all unemployed.
That's it. And the universities are ruined because they depend so much on this research. The research is a real cornerstone for many of these research universities, and it is a centerpiece of the world, in the world,
Well,
too.
so that's important for Americans to understand, is that every other country, when you get a job as a professor, the university pays your salary. Not in America. So as a research professor, I must raise my salary through NIH grants. And if I don't do that, I get fired.
And you need a begging bowl is what it is. That's essentially what it is. You depend on that year after year. And
well, it's
so
almost
on.
like a GoFundMe.
Yes,
And,
exactly,
yeah.
exactly
So
that.
we're all very vulnerable.
Exactly.
Without
And-
NIH grants, we're out of a job.
Right. And here
all
we've
of
had
us.
a huge attack on universities. So on
Well, that explains the panic, is that we're all about to become unemployed.
Yeah, right. And I thank you for bringing that up because that's that's the fact that other universities around the world do not do things like this.
No, it's a uniquely American
that's
problem,
a very
yeah.
American thing. All your work, you've got to have a begging bowl to run around and get this funding.
It's always been like that, yeah.
Yeah, and I know that here, but I didn't know about the across the country. So we have the direct costs and the indirect. Direct costs go to the research
Yeah.
specifically, and indirect for all that stuff.
the lights on,
Yeah,
yeah.
exactly. And it's expensive, and so that is an important thing. And then the impact of the NIH funding cut down here, I did not have the impression that that was legal.
It is not legal.
Okay, so it
So
was.
NIH goes to Congress every year and asks for an allocation to support research and whatever. The National Cancer Institute has a separate approach to Congress. They don't do it through NIH. But in every case, Congress says, this is great, we're going to give you X number of $1 billion this year to do research. And Congress gives the money, and only Congress can take it away. It cannot be done by executive order.
Okay, and so here
That's
we
the
had.
point of Congress.
Yeah, and here we had basically one or two people walk in and eliminate all this stuff.
Well, that's illegal.
And it's illegal, but then you need a judicial system to get back that money.
Bingo.
And we don't have that either. So we're in really trouble. And what do you think in our last few minutes here? Will we recover? Like, you're able to do some work now, right?
Yeah.
I mean, like projects that are,
So my grant runs out in August.
okay. And then after that,
I don't have anything else coming in.
whoa.
So I'm writing grants, but I have a feeling that none of them are going to get funded. NIH, there's chaos.
Oh, it's total.
It's chaos, and people are being fired, and people are leaving, and people
Right.
are retiring,
Right.
and the institution's overwhelmed. And it's not just NIH, it's
No,
FDA
yes,
and CDC,
absolutely.
all of these federal agencies
Right.
are demoralized, and I think that's deliberate.
Yes, that's very,
yeah.
very clear. That
Yeah.
there's a reason for all this. And
Well, what I don't understand is, this country, with the Apollo program, we put a man on the moon
Yeah,
not
right.
that long ago, and now suddenly we want to go back to like the 19th century.
Oh,
or, like,
except that some people want to go to Mars. Don't forget.
yes, well.
I won't mention any names, but they're building rockets to go to Mars.
The point is that the American people want this. The American people want new drugs and new
Right,
therapies,
right.
and it's all going to go away.
And they want federal control.
So graduate student cohorts are being slashed.
Yes.
So the University of Iowa and Pittsburgh, for example, no graduate students
Yes.
at all
Isn't
this
that
fall.
horrifying?
And so once the pipeline dries up, that's the end.
Right. And
So there's no future.
Right, and about 75% of the last thing that I saw on this, 75% might be like the younger scientists, the grad students, so on, but of the science community in this country is leaving.
Well, they've had the door
That's-
slammed on their careers.
They have, and so in order to continue, other countries will grab them, I
For sure.
hope. But it's goodbye to the United States as the center, as the focal point for
Well,
this.
isn't that a dumb thing to do?
Yes, it is a dumb thing to do. Do you have any happy words to end with?
No.
Or no?
No.
Do you think that there are prospects of funding? Will somebody come up with an alternative?
No.
Whatever.
There is no other model.
Wow. Wow.
We're
That
in big
is-
trouble.
We are in big trouble. And do you think that there's anything the public can do?
Yes.
Get knowledgeable what?
Demand that funding be restored. Demand cancer research. Demand medical progress.
Right.
The American people want this.
Right.
You have to ask. You have to insist on it.
Right, right. They are the taxpayers, but the taxpayers' money very often goes in some other direction. So we'll
People
see
understand that
today.
it's tax dollars, and yet they want the progress.
Right, Right.
Nobody
And-
wants to rely on like aspirin and Tylenol and for your metastatic cancer.
Right.
You want a new drug.
Yes.
You want something
yes.
effective. You don't want
and,
like
and you want vaccines
Yes,
and
you
things
do.
like that.
you don't want to go back to aspirin.
Exactly, right, or magic words.
No.
So, right,
So-
right. I wish you luck because you've spent years with this research. You've done so many great things.
I would say it's every waking hour of the last 35 years.
Yeah, it's really scary.
I'm not alone.
I
there's
know
mil-
you're not alone. You have a whole huge community, but
Yeah.
it's just such. It's
Well,
just
we're all
devastating.
panicked. We're
Yes,
panicked.
of course,
Yeah.
of course. So I hope that things will turn around. Let's try
Yeah.
there. In any case, we have to end now, but
Yeah, thank
I'll
you.
let you take some questions. And thank you so much.
Oh, my pleasure. Yeah, thanks.
Okay.